My name is Monique Roobol. I'm working as professor in decision making in urology at the Erasmus University in Rotterdam, the Netherlands. Well, active surveillance obviously is the result of all the early detection that has been going on with the availability of the PSA test. And all these men do not need active treatment, so luckily for now, in my view, we have the option of active surveillance, of deferred treatment. And this has been going on now for at least 20 years, but most likely 25 years. And a lot of studies and initiatives and registries have been developed on active surveillance. And I think it's crucial now that we look at all these different studies and outcomes and results and try to form some kind of consensus on how to best include, follow up, and if necessary switch to active treatment for those men with low risk prostate cancer. Well, first of all, what we have now done within this working group is to gather all the data with a systematic review, which was a huge job, I must say, with more than 15,000 publications being looked at, and in the end almost 270 were eligible for further dissemination and analytics. And we are now at the process of having done 2 Delphi rounds of questionnaires and consensus statements. And yesterday we had an impressive meeting, I must say, to discuss all the statements, which were in total 134 statements, and finally try to reach consensus on these statements. And we reached consensus in a large part of all the statements. So the next step now is to write up all these statements and provide, for now, interim guidance for all the urologists worldwide, actually, how to conduct active surveillance. But this is one part of all the work, and I think another important part of all the work is looking at all the data in detail, combining them into large data sets, which has been done now within the Movember initiative GAP3, and also try to provide level 1 evidence using meta-analysis. So the combination of the consensus and the expert opinions and statistical analysis will in the end hopefully result in guidelines, evidence-based guidelines for active surveillance for low-risk prostate cancer patients. Obviously, a big role. Within Europe, we have impressive data on active surveillance. Some of that is combined within the PRIOS initiative, already running since 2006. But obviously, all the European data and working also within PIONEER, which is a large European incentive for prostate cancer, we will combine everything and try to analyze and get evidence-based guidelines. Yes, definitely. In my view, the first key questions is actually before active surveillance, because with all the ongoing activities with respect to MRI imaging, targeted biopsies and risk stratification, so before MRI, which is extremely important, we will hopefully reduce the number of low-risk prostate cancers that is actually being detected. But for now, obviously with all the cancers that are being detected and are considered low risk, we need active surveillance. So the first steps indeed are exactly what we try to address, diminish as much as possible the detection of low-risk prostate cancer by proper upfront risk stratification and perhaps MRI imaging and targeted biopsy. And if these cancers are still being detected, try to follow as much the recommendations and the expert consensus, which we are now writing up. So that's the next step for 2019, I guess.